Okay, let's finish the last topic of the program, not semester. Last topic of the program. And yeah, okay, all right. Let's first review the liver very briefly. So everybody's seen liver tissue, right? You've been at the grocery store, you've probably eaten liver. Okay, delicious. Okay. Before we eat it though, it was very red and squishy, correct? It's moist, red, squishy. Because why? Why is it red, moist, and squishy? It's full of, and what color is it? Dark red, right? So why is it dark red? Very bloody, okay? Very vascular. So it's a highly vascular organ, very red. It's the last organ before blood returns to the heart, correct? So if you look at the cardiovascular system, the venous system before the blood vessel, the portal vein before it become is the last vein before it becomes the inferior vena cava. So you can imagine it's like a doorway into the heart if you look at it that way, correct? So all organs starting from the GI tract, from the esophagus down to your toes, all that blood drains into the portal vein and then enters the inferior vena cava. So if something goes wrong with the liver, with the portal vein, what will happen to venous drainage from all the organs in the lower part of the body, in the middle and lower part? If the portal vein, so let's say instead of a red, squishy, moist organ, I put it on the grill, put a little salt on it, some soy sauce, put it on the grill. 2 minutes on each side. What will happen to that nice, red, squishy liver? It's gonna contract, correct? Okay, so what happens to the blood vessels running through it? Okay, they are obstructed, correct? So again, imagine if every other organ that has to drain into the portal vein cannot do that anymore. So what will happen to all those organs? They will they're congested, right? There will be congestion there. All right. So the once we look at a patient with liver cirrhosis, that's really what happens. It's like literally you put the liver on the grill, cooked it for about 2 to 4 minutes, and that's what it looks like now, right? And then you can just imagine the consequences that will happen. So we're not only dealing with the liver disease, but also the consequences that come with it. Are we clear? All right. The nice thing about the liver is it's very resilient. What does resilience mean? No matter what you throw at it, it will, yeah, it will come back. It always tries to keep working, okay, no matter what stresses you put on it. So resilient that even if 5 to 10% of its tissues are left, it will still work. It will continue to work, even if there's only 5 to 10% less remaining functional tissue. All the rest were cooked. It will continue to work, which also means that once the patient already has manifestations of the disorder, is it early or late? It's already too late. All right, because of that resilience. So most people who are, let's say, chronic alcoholism, which is the most common cause of liver cirrhosis, we call that Lennox cirrhosis or alcohol-induced cirrhosis. Other causes are from viral infections, hepatitis specifically. So hepatitis B, hepatitis C can lead to cirrhosis as well. And there's also a small portion of the population of cirrhotic patients that develop the disease because of biliary obstruction. Because of a gallbladder stone, a common bile duct stone, but that's a small percentage. Okay, majority of our cirrhosis patients are alcoholics. Okay, so I already explained the importance of the circulation inside the blood vessels inside the liver. So the liver is not the only organ depending on the portal vein. All the GI tract and lower extremity venous drainage depends on that portal vein, right? So it's the last gateway for blood to enter the heart. So here's the structure. So this is our liver, and we have the pancreas here at the back of the stomach. And again, imagine there's a esophagus here in the middle, and that esophagus drains into the same portal vein, just like all the other GI organs. So the bowels, the stomach, the pancreas, the spleen, all drain into that portal vein, not just the liver. So can you say that all other organs depend on the liver as well? Yes. Okay. So here are the hepatic cells under the microscope. So let's review the functions of the liver and then imagine if all these functions are gone. So we'll follow the same pattern as we did with the kidneys with the first module last semester in your 241 course. So we will see what happens to the rest of the body once the liver and its functions are gone. Glucose metabolism. So it plays a role in converting excess sugar into what? Glycogen, right? We turn it into glycogen and also excess sugar into fat and store it in the liver as well. It's responsible for ammonia conversion, meaning this is the only organ that will help us excrete or eliminate ammonia. What is ammonia? It's a waste product from amino acid metabolism, meaning this is a waste product from protein metabolism. So we use protein, what's left over is ammonia, and the liver destroys ammonia. So what happens to ammonia levels when the liver ceases to function? Increases, okay? And then it's a toxin. The most affected organ here is the brain. Brain will be destroyed by ammonia. So these people will develop encephalopathy. Literally, they are crazy. Okay, very serious mental status changes because of toxins in the brain. Protein metabolism. So therefore, if the liver ceases to metabolize protein, what happens to your albumin levels in the blood and in the body? So we want to increase protein in the body, we destroy our liver. So what happens to protein metabolism when the liver ceases to function? This will decrease. And what's the role of albumin or protein in our body? This is the major component of plasma, right? So plasma is made of 70% water and 20% albumin. So therefore, if you have no albumin, little to no albumin in your blood, can water stay in your bloodstream? So what will this patient look like? What else? Will water stay in the bloodstream? It will leak. Where will it go? Interstitial spaces. So it will cause edema not only in the legs, but edema in the abdominal cavity. What do we call that when we have ascites? Okay. Another thing is albumin is also the major component of making clotting factors. So without clotting factors, what will happen to the patient's bleeding time? Yeah, at risk for bleeding. Okay. Then fat metabolism. So therefore, no liver function. Can we absorb vitamins, fat soluble vitamins, A, D, E, and K? No. Bile formation. Who makes the bile? Is it the gallbladder or the liver? Which one? The liver makes the bile. Where is it stored? In the gallbladder. All right. So can you digest fat when you have no more bile? So the changes here, what will be the color of your stool? Will it still be brown? Okay, that will change the color of your urine as well. Bilirubin excretion. So therefore, if the patient can no longer excrete bilirubin because the liver ceases to function, so what will be the changes? Rihanna, what will the patient's color be? Yellow. Okay, so we got jaundice there. And drug metabolism. So only the liver metabolizes all drugs. So when the patient's liver ceases to function, do we have much options with medication administration? So will we still give this patient the same amount and doses of medications? Because let's say this patient has heart failure. Will they be on medications? They have diabetes. They have renal disease. All right, so all drugs here are going to be affected. We will have to change the dosing and the frequency of all medications because drug metabolism is a major problem.
That's still 3 years to lose.
Okay, so this is just the anatomy and physiology review. We still have to look at the consequences once the liver starts to fail. For diagnostic testing, what are considered liver function tests? What are the two liver enzymes that we will examine? ALT and AST. Okay. Others will, of course, will look at albumin levels. What else? Will we look at bleeding times, PT, INR, PTT? All right. So these are all very helpful in diagnosing the liver function. Okay, so once PTT, PT-INR rise, what does that mean? Is the liver synthesizing albumin? Because remember, again, clotting factors are dependent on albumin. Okay, they are made together with vitamin K. They are made in the liver. Liver biopsy. If a patient undergoes liver biopsy, just imagine if you insert a long needle into the liver and aspirate tissue sample. What's the number one complication after the procedure? Because it's a very red, squishy organ, bleeding. Okay, so watch the patient after liver biopsy for bleeding. For table 43-1, please look at the third column, right? So what is the significance of the test? For example, so in liver disease, what do you expect the albumin levels to be? In liver disease, so what would you expect the albumin levels to be? Low. Okay. So on, remember you'll be getting next gen questions. So on the chart, for instance, I'll give you a chart on the EHR showing lab results, and then you're made to choose, you're asked to choose, okay, which ones are expected in liver cirrhosis. Remember the drag and drop? So you still have those drag and drop options on the exam. Please read the instructions because a couple did not follow instruction that said all the findings below, and then you only chose 2 or 3 findings when it said all clinical findings below. Okay, so again, PT-INR will be elevated, okay, in liver disease. AST, ALT will both be elevated as well. Ammonia, definitely high. Okay, let's go now to the manifestations of liver disease. let's start with this page. So as a result of the liver's inability to excrete ammonia, the consequence mentioned here at the bottom, the last paragraph, is hepatic encephalopathy. So this patient can go into a coma when the ammonia levels are dangerously elevated, right? So in hepatic encephalopathy, the patients at this point very yellow because all of these are already present. So there's already jaundice, there's portal hypertension. That means portal hypertension is when the portal vein is already very constricted. That means what happens to the blood flow through the liver? Already very congested. So that's what we call portal hypertension. And as a result of that, there's ascites already. Now, varices are basically varicose veins, but they're not in the legs. They're in the esophagus. We call them esophageal varices. Not just in the esophagus, but also throughout the GI tract. Patients will also develop hemorrhoids as a result. However, the most dangerous here is the esophageal varices because the varicose veins, let's say if this is your esophagus, okay, this is where food enters. The esophageal varices or the varicose veins on the esophagus is not here. It's inside where you swallow, where tacos go in, while alcohol goes in. That's where the varicose veins are. So when you eat something spicy or very sharp, let's say chicharron, you did not chew very well, okay? You ate chicharron or whatever else you put into your belly. What will happen to those varicose veins in there? They could bleed, right? They could bleed, and then with the patient, once these things burst, what will happen? GI bleed, aspiration, hemorrhagic shock, hemorrhage, and hypovolemic shock. So watch every, and I mean every cirrhotic patient admitted to your care for bleeding varices. We already assume when patient comes in already yellow, meaning did this occur overnight? Did this happen over months and years? Over months and years. So therefore, there's already varicosities in there in the esophagus. Okay. Jaundice, you already know. Where do we look for jaundice in darker skinned people? Okay, the eyes and anywhere there's less pigment. Okay, so the lips, for instance, and the palms and soles of the feet. I don't ask particularly what type of jaundice because for me, I mean, does it make a difference? What type or what led to that jaundice? No, the skin and the eye color will be the same regardless. We'll skip that. Okay, let's discuss portal hypertension now. Now, this is again caused by the narrowing of the portal veins because of the what happened to the liver again? Okay, the liver is now decreasing in size, shrinking, okay, because you cooked it with alcohol, you had hepatitis B or C, for instance, so it now shrunk. So therefore, what happened to the patency of the portal veins? You squished it, okay, there's now constriction. So this causes portal hypertension. Although we can treat this with beta blockers, calcium channel blockers to try to dilate, is it going to be any effective if it's actually the liver tissue that's causing it to constrict? Okay, not much help, right? But it's better than nothing. So they will respond to propranolol, for instance, okay, beta blocker therapy, but only to a certain extent. This will, of course, cause the increased congestion. Remember, imagine congestion in the last organ before all the blood coming from your feet, from your legs, from your each of your GI organs cannot drain back into the heart. That means what happens to cardiac output? decreases. Plus now the fluid, of course, because of congestion, just like if there's congestion in the pulmonary circulation, what happens again? What does the patient develop? Like such as in heart failure, there's congestion there inside the heart and the pulmonary arteries. Patient develops what? Pulmonary edema, right? And you hear crackles. So here, there's also congestion inside the liver. So what will happen there too? Edema as well. So same mechanism. There will be increased hydrostatic pressure. Water will be pushed out of all those vessels. And where do they go? Into the abdominal cavity, into the peritoneum, and in the legs. So forming your ascites and of course, the esophageal varices again. So here's ascites. We already discussed this a few times. Where did this come from again? Where did this water come from? From the portal hypertension. Okay, so from the congestion of the portal vein, they will leak water out, and there you go. There's ascites. Now, what could possibly go wrong if there is ascites? So what if I have so much fluid in my belly? What's wrong with that? And what happens to diaphragmatic expansion? Can my diaphragm still push down? Okay, so will that affect breathing? All right, so there's consequences. Yeah, of course, there's consequences here. Because where is this water supposed to be? Where is this water supposed to be? In the bloodstream, right? It's supposed to be in the bloodstream. Is it in the bloodstream? No, it's somewhere where we can use it. Plus, it's impairing ventilation. So now the patient has low blood pressure. But if you look at the patient, very large belly, very edematous extremities, do you think they're in fluid deficit or fluid overload? You would think they're all in overload, right? But what's the reality? There's actually in deficit because that water is not supposed to be in the legs or in the abdomen. It's supposed to be in the bloodstream. So again, what's the patient's main problem? Deficit or overload? Actually deficit. So this is what we call also third spacing. Now, did the water get there simply by sheer hydrostatic pressure? Or is there also an albumin deficiency component? There's also an albumin deficiency component. So this is actually third spacing because the edema in cardiovascular problems, in heart failure, was that an albumin deficiency? Or was that from hydrostatic pressure? Hydrostatic pressure. This one, is this only hydrostatic pressure? No, this is also caused by albumin deficiency, which causes water to leak out of the blood vessels, okay? Because there's no albumin in the plasma, so they go somewhere else. Manifestations, these are just a few. So the abdomen will increase. There's rapid weight gain because of the ascites. They short of breath because of the decreased diaphragmatic excursion because of the large abdominal cavity. There's stretching of the skin of the abdomen causing stretch marks. These distended veins will look like spider angiomas, okay, over your abdominal wall. They can, because of the increased pressure in the abdomen, they'll form hernias. Okay, not only in the umbilicus, but also around the groin is possible. And fluid and electrolyte imbalances are common. But remember, there is protein malnutrition here. Okay, and that can be a problem when we take care of the patient. Now, I want you to understand the diet here. Remember, the patient has low albumin, correct? So therefore, do they need more or less protein? No, yeah, the liver can't make or synthesize albumin. So do they need more protein or not? So we don't give them any protein at all? So do they need protein or not? Yes, they need protein because they're very low in albumin. They need protein. However, what is again gonna happen when we metabolize protein? No. We're not asking the liver to metabolize it. We're gonna give them protein. But you said what is always a consequence when protein is metabolized? Ammonia. So therefore, the more protein you give them, the more ammonia you will produce. So the decision to control protein really depends on what will the doctor have to determine first before issuing a diet, or how much protein to give the patient? Ammonia level. So once the patient's ammonia levels rise, then do we give them normal amounts of protein? We will have to restrict protein at that point. But until then, if the ammonia levels remain low or normal, do we give more protein?
Yes.
Yes, they need protein. Hey, they need to heal. Hey, they need protein. They need energy. You give them protein. When do we again restrict protein? Okay, definitely once the patient already has mental status changes, which is a manifestation of encephalopathy, do we give protein?
No.
We restrict protein at that point. Okay, because again, the more protein you give, then the more ammonia the patient will produce and retain, because the liver cannot destroy or eliminate ammonia anymore. So we measure abdominal girth. Okay, measure it at the same spot. Don't measure, today you measure here and then tomorrow you measure here, and that's not no good, right? So you measure around, we typically measure at the level of the umbilicus, of the belly button. Measure that every day, and if it's increasing, we weigh the patient also, and then the doctor will decide whether or not to tap it, okay, to drain it. Okay, medication, medical management. First is nutrition. What do you think we will do to the diet? High or low sodium? Okay, low sodium. Besides sodium, again, what do we do with how do we decide with the protein? Okay, check the ammonia levels first, and then control the amount of protein if needed, or restrict the protein if needed. You still know about salt substitutes, right? We talked about this in heart failure.
Yeah.
Okay, so make sure you, because we haven't talked about it yet, but there's something we call hepatorenal syndrome, which means once the liver fails, because the liver helps eliminate waste products, ammonia in particular, will that affect the kidneys as a result? Yes, because the kidneys, although it's not their main job, will help eliminate ammonia as well. However, its only job is to eliminate waste products, not destroy them or metabolize it. So therefore, if ammonia is not metabolized, then it will destroy the kidneys as well, leading to more acidosis. Okay. The fluid and sodium restriction, again, depends on how bad the ascites is. Let's go to drugs. Diuretics will be issued. However, keep in mind that is it easy can we just indiscriminately use the diuretics here, knowing where did this fluid actually come from? Okay, it's really from the bloodstream, right? And it's leaking outside. So in reality, the patient actually has fluid deficit to begin with. But we will use diuretics along with sodium restriction to control ascites, of course, in high or smaller doses. Smaller doses. Because remember, the patients cannot do well with drug metabolism anymore. But like I said, is the liver resilient? Yes. So even if they already have cirrhosis, there is still some functional liver cells found all throughout. Here are contraindications. Again, this will help increase ammonia levels, so these drugs are not or are avoided. For daily weight loss, this is in relation to diuretic therapy. We should not through diuretics, okay? I'm not saying through paracentesis. Through paracentesis, that's the procedure of draining the abdomen. But if you're using diuretics to decrease the abdominal girth to control ascites, the daily fluid loss is about what? How much is 1 kilogram again? How much is this? No, how much fluid is this? We discussed this last semester. 1 liter. So 1 kilogram is equivalent to 1 liter of fluid. What about 1 pound? 500 mLs or half a liter. And of course, with any diuretic therapy, there's always complications. Patients may have too much fluid loss, resulting in fluid and electrolyte imbalances. These patients are placed on bed rest. So the same thing, whether it's cirrhosis or whether it's hepatitis, is the patient able to produce energy? If the albumin levels are low, waste products are high. No, patient will be placed on bed rest. Here's the procedure. Paracentesis is to drain the acidic fluid. So the doctor will insert a needle attached to a catheter inserted into the peritoneum and drain to drain fluid. Now imagine the abdominal cavity. So you have your stomach here, you have loops of bowel here, small intestine, and you have the ascending, transverse, and descending colon. So therefore, if there's fluid in my abdomen, are they in one spot? If I have ascites, will the fluid be in? It's scattered everywhere, right? So even if I tap here, if I insert the fluid here, is it gonna drain all the fluid that's here? All right. So most doctors before the procedure, at least in America, they will order an ultrasound. They will order ultrasound to map right here, ultrasound guidance to map the abdominal cavity. So the ultrasound tech, after doing the procedure, will literally mark with a marker, where are the largest pockets of fluid to maximize fluid removal. Because will you just randomly insert it? No, I would go where is the largest accumulation? That way, when I tap it, when I insert the needle, I get the most amount of fluid out, right? And of course, during the procedure, the patient will be asked to turn from side to side, to move the fluid around. That way we drain even more. Depends. If the patient, depends on what stage and how often the fluid is accumulating. If the patient's already at end stage, which is stage 4 liver cirrhosis, they go like 3 times a week, like dialysis. Sometimes if they choose to stay home, they come in every week. They just go to the ER, get the fluid drained, go home, right? Because they're pretty much end stage. They know they're dying. They just want some comfort, because rather than, I mean, can you stay at home when you're breathing like this? Because your abdomen's so big. No, you're forced to go seek help. Okay, and then they already know the drill. They go in there, they go in for the same thing, tapping it. We'll discuss the alternative therapies later toward the end of the chapter. The fluid will be sent for cell count, albumin count, and total protein levels, and culture as well. We want to see if there's bacteria growing in the fluid as well. That's every time. So for every paracentesis procedure. Sorry? Yeah, we send it for culture. The ascitic, the peritoneal fluid can grow bacteria. So we can drain as much as 5 to 6 liters of fluid. So that's 5 to 6 kilograms of weight loss. So this is only for paracentesis. Again, what's the limit for diuretics? About 1 liter per day, right? This one though, this is paracentesis, so can we drain more? Yes. After the procedure, the doctors usually order albumin infusion. Albumin comes in a glass bottle, just like Alteplase. So you'll hang and what do we always do when it's a glass bottle? When you spike it, what do you open? The vent, okay? The vent on the IV tubing so that the fluid will prime. Otherwise, you'll have poor air displacement. It will not prime. Okay, so you may be ordered to give 1 or 2 vials of the albumin, depending on how much fluid they remove. Because when they remove fluid, are they also removing albumin? Yes, because there's albumin in that fluid, in that ascitic fluid. Your main responsibility when you send the patient for paracentesis is, if possible, if safe, do not give any anticoagulants that day. You can give it after the procedure, but not before. Weigh the patient, definitely, because we need to compare how much fluid was removed. We also need the patient to void because the needle might be inserted in the lower abdominal region, which if you have a full bladder, what could happen? Yeah, you may insert the needle into the bladder and then same fluid comes out, fluids come out, and then you think, oh, this is paracentesis. No, this is the bladder that you nicked. Okay, so now you created an injury to the bladder. So always have the patient void before the procedure. Okay, immediately before the procedure, like in the last hour, okay, before you send them to the procedure area. Okay, this is the alternative. So let's say the scenario is the patient's end stage liver disease. They've been coming to the ER 3 times a week. Okay, no way to live, right? I mean, how's that? You can just imagine the amount of fluid accumulation if they have to go to the ER 3 times a week, okay, just to get their abdomen drained. The doctor will discuss this option, meaning the patient's going to die anyway. So they'll suggest, let's do tips. So we'll make your last days or last months more comfortable. Okay, we'll give you better quality of life. Let's do a shunt. So this is called a transjugular intrahepatic portosystemic shunt. The picture is here. So this is the shunt right here. So they'll put it in the inferior vena cava, bypass the portal vein altogether. So this is now the liver, right? So they'll just put the shunt from the inferior vena cava all the way down here, meaning will blood pass through the liver at all? No, all blood coming from the esophagus, lower extremities, all GI tract organs will go through the shunt straight into the inferior vena cava. So will there be portal hypertension? No more. Will there be ascites? No more, because you bypass the obstruction. So therefore, will blood flow, blood return be increased? What happens to cardiac output? Good, right? Will there be ascites? Will there be shortness of breath? However, since it bypassed the liver, is it going through any of the liver cells for cleaning? Remember, I said what is the characteristic of liver cells? The liver organ, very resilient. Even if there's only 5-10% left of the liver cells remaining, do they still work? Yes, even if there's 10%, they will still clean the blood. They will still remove ammonia. Is that happening when you put a tips in? No more. So what happens to the ammonia levels after this procedure? It will increase. All right. But is it worth it? Yes, it's worth it. However, don't worry, there's other ways to get rid of ammonia. All right. Look at this. Because the development of ascites in patients with cirrhosis is associated with 50% mortality rate, then that's why they recommend tips. All right, to again make their lives more comfortable, maybe buy them a few extra months or a year, maybe. All right. So patients will resort. Is this again a first line treatment tips? Only last resort. Okay. Okay, so let's go now to the management of ammonia. What do we do with ammonia excretion? Let's go to drug therapy, next page. Let's do esophageal varices. You still remember GI bleeding, right? From peptic ulcer disease. Okay, so same management. What are signs and symptoms of GI bleed? Okay, what does the vomit look like? Yeah, either bright red or coffee ground. What will these stools look like? Yeah, black, right? Black, really smelly, right? Okay, so no difference. How do we know they're bleeding? What if there's no vomiting, there's no bowel movement? How do you know they're bleeding? Okay, vital signs changes. Okay, so always monitor patients for hidden and overt signs of bleeding. Who again? Cirrhotic patients. Okay, so always assume there's esophageal varices in these patients and they're always at risk for bleeding. Okay, so do you want them to, is it okay to just shove NG tubes in these patients? No, because you could perforate those varices, okay? Although when they're already bleeding, then we're forced to put in an NG tube because is it safer to suck out the blood or ask them to vomit it? Okay, suck it out because when they vomit, of course, that's always risk for aspiration. Remember, do these patients have any energy to vomit? No, and no, these are malnourished patients. They have no energy for that. So when they're too tired to sit up and vomit, they'll just vomit when they're laying down. And of course, that causes aspiration. So again, these varices are very fragile, prone to rupture, prone to bleeding. When they do bleed, because we can't stop the bleeding, we have interventions here on how to, so here are again the plan of care. Okay, watching for signs of bleeding, monitoring output. Let's go to management. So because the patient can die here from hemorrhage or from hypovolemic shock, here are again signs and symptoms. Management is once stable, they'll be taken by stable, meaning what did we do again in peptic ulcer disease that had bleeding? What did we do for the patient? What was the first thing we gave? You're bleeding. It's priority. You did this in peptic ulcer. Fluids, okay. So a little bit or a lot? Bolus, right? Yeah, because this is, remember, this is hypovolemic shock. So you give massive amounts of isotonic fluids, and then once the blood pressure is stable, and then blood's available, we start transfusions, okay? And then once the bleeding is controlled, by the way, with controlling bleeding, we have a drug here. We give octreotide. Okay, the brand name is Sandostatin. So this is IV. You've probably seen this drug also in patients who have chronic diarrhea. Let's say they have an ileostomy. We use this drug also sub-Q, but octreotide in this case will be given IV, continuous infusion. And will they benefit from Protonix also? Pantoprazole, proton pump inhibitor. Okay, that will also be running. So you got PPI, you got octreotide IV infusion. So that will help slow down bleeding. Again, the fluids first and then blood transfusion. So once stable enough to go for endoscopy, then they'll be taken to endoscopy and literally stop the bleeding. Okay, so they'll burn the bleeding vessels, or if not, they'll clamp them, whatever is needed to stop the bleeding surgically. Then we continue the octreotide, okay, and the PPI as well. If needed, we'll give vasopressin, vasoconstrictor, but keep in mind this is given IV, so therefore will this only constrict the blood vessels in the esophagus? Will constrict everything. So what happened to coronary arteries here? Also constricted. So will there be possible chest pain, ischemia here? Okay, that's a consequence of this drug. So here, that's why if the patient has serious coronary artery disease, then can we give vasopressin? No, that's not an option. We'll just stick with the octreotide. Okay. I already mentioned beta blockers earlier, so this will help with the portal hypertension. Among the drugs mentioned here, it's really just propranolol that we use for liver cirrhosis. Keep in mind, beta blockers cannot be given during acute bleeding. Why? What is the effect of beta blockers? They are vasodilators, so therefore, are they good during acute bleeding? No, only when bleeding has stopped or slowed down. Okay, now for acute bleeding, I mean, the patient is actually, vomiting bright red blood or massive amounts of blood. We will put in a Sungstaken Blakemore tube. This is what the tube looks like. It's a huge tube. It's like a Foley. 3 lumens. So this is what it looks like. I lost the picture. Oh. You see the picture here? Okay, so it's an NG tube, has 3 lumens. So they're gonna insert this. It's quite huge. The balloon is probably the diameter of your thumb. This big. You insert that through the nose. Okay, through the nose, then guided by X-ray, so we can see where the tip is. Then once we locate the tip or verify the tip, we'll inflate the balloon. The pressure must be only to a certain extent. So this will press on the bleeding varices. So the varices typically are located here. That's where the bleeding usually is. And it's also gonna anchor, not only anchor itself to the antrum of the stomach, but also because the varices extend around this area. So this large balloon here will also compress on the bleeding varices. Okay, so 3 balloons here. 1 balloon here, second balloon. No, two balloons. And that's how we stop the bleeding. So this will be in place for 24 to 48 hours. Now, because it's a huge tube, can the patient breathe very well? Can they swallow? What's a number 1 complication of having a tube like this? Aspiration. But again, is this something we leave for a long time? No, this is only for about 24, 48, the longest. Okay, just to stop acute bleeding. Because again, the patient has to breathe somehow, right? Again, aspiration is a concern with these huge tubes. Imagine the tube this big, right? It's very hard to swallow. So this is only for, this is part of what we call a rescue therapy, okay, emergency purposes. We only see this in the ER. Okay, the patient won't have it when we reach the floor. Okay, so just to stop the acute bleeding while we're giving fluids and giving blood transfusion, at least compress it, and then we start the octreotide infusion, okay, to slow down or stop the bleeding. So here's your warning. What could happen with tubes like this? Aspiration, esophageal ulcer because of the size of the tube and the balloon. And make sure they don't pull it out. Imagine they pull a tube like this out. Be a disaster, right? With the balloon still intact. Because remember, these patients, are they encephalopathy already? Yeah, they have mental status changes at this point, okay, when they start bleeding like this. So this could happen in a nursing home, okay, because that's where we'll see these patients, or at home, okay, in an apartment. They're already very yellow, right? Here's another option, endoscopic sclerotherapy. So they'll do again, take them to endoscopy and then literally burn and sclerose the bleeding vessels, the bleeding veins. So these are the sclerosing agents they use: sodium morrhuate, ethanolamine, or they'll do ligation, like binding, wrap a band around the bleeding vessel. So here are the ligations. They'll wrap bands right there or do this. So this is what I mean by, look at the size of these varicosities. And this is your esophagus. Quite huge. Okay. Then there's your tacos going in there. Okay. Eat tacos and then tequila running down. Yeah. And what else do you eat when you drink Brianna? Chicharron? Empanadas. Yeah, chicken wings. Okay, we already discussed the tips. Drug therapy. So when we let's look at drug therapy now for ascites. No, sorry. For encephalopathy. So we will give the patient lactulose. Who has ever given lactulose here in clinical? What does it look like? What color is it? Orange, right? It comes in a plastic cup like this, like a Jello cup of Jello. It's about 60 ml, right? And you open it and it has a thick orange liquid in it. Tastes nasty. So that's what we give the patient. So how does the drug work? It's technically a laxative. Because it's a laxative, what will it do? Cause a BM. That's our goal. We give them lactulose because the lactulose here will hold ammonia into the stool and helps the patient excrete it. So meaning if the liver can't get rid of the ammonia, we'll let the GI tract do it. Okay. So how much lactulose will we give? Well, you keep giving lactulose until the patient produces so here's how the drug works. To successfully eliminate ammonia, the patient must make 2 to 3 soft stools per day. If they're not making 2 to 3 soft stools per day, did we give enough lactulose? No. You give more. All right. So you give lactulose in order to have what effect? 2 to 3 soft stools. Do we want them to have diarrhea? No. When they have diarrhea, as you've given too much. All right. So what's the goal again? Okay, so will the doctor say 1 lactulose? No, it will be, yeah, give lactulose until, yeah, the patient makes 2 to 3 soft stools per day. So 2, we typically stop because we know there could be a third one, right? Because, I mean, you got the bowels moving. Clear?
So after a while, you have a patient, right? Do you,
And this is forever.
yeah, but do you know after a while, when you start having the same patient, do you know the amount that we need to take for that patient?
Yeah, I mean, you know, if you live in, I mean, if you work in a long-term care facility, which most of these patients are, so yeah, you get to know them, you know, and then, oh, they typically get 2, okay? So they give them 2 lactulose and then that's it for the day. Signs and symptoms of encephalopathy. Here they are. So the patient has obviously mental status changes, they're confused. They could go into seizures depending really on the stage because the ammonia levels rise depending on which stage. I mean, they have a certain level at which stage. Asterixis is what we call flapping tremors. So the patient will have this when you have them raise their hands and then they do this. Okay, they have this tremors, flapping tremors. That's called asterixis. This is usually stage 3, no, stage 2. Stage 2 encephalopathy and up. So that's pretty serious already. So when you see this, this indicates the nerves are already very actually irritated, okay, because of the ammonia. So the brain, the nerves in the brain cells, okay, are already very irritable. Okay, that's why they have the flapping tremors when they put their hands up in the air. Their breath smells like poop. That's what fetor hepaticus means. It's literally poop. Okay? Their breath smells like poop. Seen patients die at this point. I mean, and then when they talk also this very mouthy, you know? They talk like, dad, nurse. And then all that poop is just, you know, it's like they're farting through their mouth. And these are indicators, again, indicating nerve irritation already. When they write, you know, ask them to draw a star, that's what their star is going to look like. And this is what their handwriting will look like. What's the only way again to manage encephalopathy? Lactulose. There's really nothing else unless the patient gets a liver transplant. So we already discussed this. They get diarrhea. That means we've given too much lactulose. You overdid it. And here are your nursing care. So neuro checks every 4 hours, vital signs as well every 4 hours. Record ammonia, and remember what do we do with the protein at this point? Okay, restriction. So the diet here is protein restricted to 1.2 to 1.5 grams per kilogram per day. That's not much, right? So can they drink Ensure? Okay, those things, those supplements are very high in protein. Okay, so no good. Okay, and then to control the manifestations, because these patients can be violent, aggressive, so we give them sedatives, tranquilizers, anti-anxiety, or sedatives. Just be careful with the dosing again, because can this be harmful? Yeah, this cause more harm to the liver. The more each drug you give, it's always gonna cause harm. So here's the nutrition therapy. There's not much again besides nutrition and lactulose. That's all we can do with encephalopathy, okay? Because the cause of this again is high ammonia levels. That's it for cirrhosis. Let's go now to hepatitis. The hepatitis part is easy. If you look at the blueprint, all I'm asking is or are how is it transmitted? Because if you know how it's transmitted, can you prevent it? Yes. So if you know how do you get hepatitis A and E? How are A and E transmitted? Oral fecal route. Okay, so contaminated food and water. However, when you perform oral sex, when you engage in oral sex, can you get hepatitis A and E? Yes, because is there microscopic fecal matter in the genitals?
Yes.
Yes. Okay. In the females especially, right? I mean, it's anatomy, you can't help it. Okay, the anatomy puts the vagina very close to the rectum, right? And then women, don't. How are you supposed to wipe? Okay, front to back, and then sometimes people go front back to front. Okay, there's your fecal, material, and it goes into the oral cavity of the partner. So here it is. Table 43-4 tells you the how is it transmitted. So A and E are both oral fecal. A and E. Both acute. There are no chronic forms of A and E. B, C, and D are all bloodborne. Okay, so blood or unprotected sex, just like HIV. Okay, so B, C, and D transmitted the same way as HIV through unprotected sex or through wounds or through blood or needle stick injuries. The only thing with D is a reverse RNA, meaning it can't enter the host unless the host already has hepatitis B. Okay, so even if I expose you to D, if you're not infected with B, you cannot get D. Are we clear?
Have to be infected.
We have to have B first. Okay, you cannot be infected with D unless you already have B. It's impossible. This virus here, the D virus, cannot enter the body or the cell unless it's assisted or helped by hepatitis B. Okay. All right. So you know about mRNA, right? And the when we did the vaccine, so same idea. Okay, so D cannot enter the cells unless it helps. I mean B helps. Right. So if you have D, that means you must also have. Very good. So which among these have vaccines? B have vaccines. What else? No vaccine for C yet. We have treatment for B and C, but no vaccines. So A and B are the only ones that are preventable. Okay, so we can have vaccines for A and B. So is there a vaccine for D?
Yeah, I mean.
Technically, yes.
Yes.
Right? Technically, yes, because because when you vaccinate for B, then you're effectively vaccinating against D. All right. Okay. So could that be a good select all that apply question? Okay, just make sure you answer correctly. All right. Read the question. Yes, that's it. So if you read the next paragraph, because page by page they talk about each letter. So they talk about A, B, C, D, and E. So this will tell you how to prevent it. Manifestations will be the same. I mean, the liver is inflamed here. So will there be pain? Where again? Where will the pain be if you have hepatitis or liver cirrhosis? Where? In the abdomen. Where in the abdomen? Where is the liver? Where is that? RUQ, all right, upper quad.
Right on the 30.
And then will there be jaundice? Okay. So how do you get it? Through oral fecal, so therefore, how do you prevent it? Besides vaccination, so you clean, wash food thoroughly, right? And then you drink. And say, where is this found? Where do you get hepatitis A? Typically in third world countries, right? Yeah. So when you travel, yeah, so it's better to drink from bottled waters. Here, high-risk groups also, you can get it through IV injection as well, contaminated with the virus. If you have, for post-exposure prophylaxis, meaning you didn't have a chance to get the vaccination, then you'd be given IV immune globulin, okay, IVIG. So this will provide immediate antibody protection. Let's say you won, okay, you won a raffle trip to Mexico, and there's a limit. You have to go this weekend. Can you get and complete the vaccination series? No, so you will get IVIG. Okay, so you go to, hey doctor, I won a week-long, trip to Mexico, but I need protection. Okay, so they'll give you IVIG and then start the first of the vaccination series. So I won't go through each page. They're self-explanatory, okay, how to avoid, how to prevent it. And then same thing for B, then C. And as far as, because this will talk about percutaneous needle injuries. You know what that is, right? No, when you get stuck in clinical. Okay. I've been stuck probably 3-4 times in my 28-year practice. Yeah, I've been stuck a few times. Just report, okay, to protect yourself, okay, rather than being hiding it and then now being paranoid that this patient have HIV, and then you go looking at and then there's none, okay, there's no data, the patient was never tested for HIV. Yeah, crap. Okay, and then now you'll have restless nights. But avoid it altogether, because it's a hassle though. If, let's say you get stuck, of course I care about you, because you need to get go to the ER, get yourself checked out. But then the problem is you're leaving the floor. It means all your patients will have to be distributed among us. Way to go, Mark. Thanks a lot. But no, don't think about it that way. Your coworkers care about you.